Hi, everybody. It's Dr. Sporbert. It's Saturday. Because of impending weather, going to be proactive and record lecture for Tuesday, I believe the 27th of January, on the pretense that we may not have face-to-face class. That does mean, however, if the campus is closed, that we will have a virtual class. That means that I will have another class collaborate session available to start at 9 o'clock. But in the interim, I'm going to be doing voiceover PowerPoints for modules 2, the pediatric acute gastroenteritis, which I'll start here shortly. We're going to talk about module 3. That's going to include the inflammatory bowel disorders of Crohn's and ulcerative colitis, colorectal cancer, because of the increased risk for developing colorectal cancer, secondary to the diagnosis of ulcerative colitis. And then we wrap up the content for exam 1 with glomerular nephritis. So there's a lot to cover. I know we're not face-to-face. Hopefully Tuesday we will be. And I'll talk more about that toward the end. But while I'm thinking of it, if we have class on Tuesday, the expectation is it would be a Q&A review, preparation for exam number 1, which will be a week from Tuesday. I am not rescheduling the exam. We won't be able to keep up with our content for the summer. So take a deep breath. We will be fine. You have to, you got to think positive. So a pediatric acute gastroenteritis, I want you to make sure, and stop me now, if you need to go back and pull up module 2 to have the PowerPoint available to you, do that now. So pause, but I'm going to keep going because that's the PowerPoint I'm using. So I'm going to share now. All right, so when we think pediatrics, I want you to think in the pediatric scope of provider practice is age 1 through 18. However, when the pediatric population as it relates to acute gastroenteritis, you're talking your little ones from anywhere, let's say 1 to 5. A lot of the focus pediatrics, because of the viral nature of this disorder, comes basically from your children who are toddlers walking with the oral fixation of putting anything and everything in their mouth. And that's how they pick up the virus that affects their gastrointestinal tract. So 2-year-olds, 3-year-olds, and 4-year-olds in daycares, at home, putting things in their mouth, toys, Legos, anything that hasn't been properly washed, sets these kids up for a gastrointestinal virus. This is not a bacterial virus. This is a viral infection. So you have a difference. The virus ones are the rotavirus, norovirus, and adenovirus. Adeno, think your nasal patches, your nasal cavities. So it could be respiratory as well, but we're focusing on the gastroenteritis. There is bacteria, Salmonella, E. coli, from not washing food really well, especially vegetables. And then you have some parasitic, which can be worm infestation that can develop from products that are not properly washed. Pork chops comes to mind, pork foods, animal meats. The risk factors are contaminated food, water, poor sanitation, close contact, and daycare. Now, the poor sanitation should drive you back to your peptic ulcer disease etiology of H. pylori, and contaminated food, water. And then close contact and daycare, because your pediatric populations typically are in daycare settings. So all I've done is really taken risk factors and just driven it down to your kids versus your adults. So what's going to happen to these kids when they end up with a gastrointestinal virus? They're going to end up having nausea, vomiting, and diarrhea. So what does that mean to a little one that's got a small body mass in sense of how fast they're going to dehydrate on you? And that's very quickly. So with hydration status, this goes back to a couple of kinds of assessments in clinical manifestation. So when we are developing a care plan, when the parents bring the baby in, hopefully, or the toddler, into the ED or the provider's pediatric offices. We want to know the onset of the symptoms, episodes of vomiting, episodes of diarrhea, the frequency of both, the stool characteristics, and associated symptoms such as fever, pale, diaphoresis, unable to sleep, very fussy baby. So the stool characteristics with diarrhea, they're not going to be formed, they're going to be loose. So we're talking fluid and electrolyte imbalance, specifically your potassium. Your dehydrated state also from vomiting is going to be losing potassium. So vital signs are going to be impacted. So within the module 2 in the pediatric gastroenteritis resources, you will see vital signs. And your kids tend to be, normal speaking, more on the tachycardic side in general, and blood pressure based on age. So please review normal vitals, but these kids are going to be pretty tachycardic because of the dehydration. If they are in a late stage of dehydration, either vomiting, diarrhea, or both, they're going to be lethargic, sunken eyes, which is determinant of poor hydration, poor skin turgor. And I don't know if you can see me, but poor skin turgor from 111 is lifting the skin. And if it tense, that's dehydration. You just don't have the elasticity from the fluid in your cells to maintain turgor. And then decreased urinary output. So BUN and creatinine. If by chance your pediatric patient is in diapers, part of the urinalysis would be the specific gravity that I briefly talked about when we talked labs related to kidney function. So your specific gravity will determine the dehydration state of the babies. So that's a pretty non-invasive test. We just take the wet diaper and we have a toolkit, and we can check the pH as well, and also assess for hydration. So what therefore do you think is the goal then? The goal is to rehydrate. The goal is to replenish and neutralize electrolytes. And the goal is to figure out which risk factors potentially provoked or exacerbated this presentation. So oral rehydration therapy is the cornerstone. What we want to make sure of when I say oral, obviously you have toddlers that are sitting in high chairs at that point. They're using sippy cups. They have the ability to effectively swallow. If we have a truly dehydrated child or baby, we're going to start IV therapy based on lab results. And babies typically will have the IV started at the top of the foot and then heavily wrapped so that, of course, we're not having the child pull the IV out. If mom is nursing, it's definitely, we continue breastfeeding for all of the healthy benefits associated with breast milk. Why would you think that I would teach parents and I would not order an anti-diarrheal medication? And the answer is because the virus has to work its way out of the child's system. So if you give them something to stop the diarrhea, then you're leaving the viral infection or the bacterial in the gut. And so you want them to get the diarrhea, you want them to have diarrhea, and you want them to vomit. The problem with all of that is that it's going to cause dehydration. So that's where we come in with the main focus of rehydration, monitoring and stabilizing electrolytes, specifically your sodium and your potassium. And then you want to make sure you teach mom and dad or whoever the caregivers are the signs and symptoms of dehydration and when to seek care, especially if the babies and the toddlers roll up in the ED with sunken eyeballs and they're lethargic and poor skin turgor and sort of limp. That's bad. So we need to make sure that we teach them hand washing techniques, teaching toddlers, especially when they're able to understand instructions, how to wash hands after going to the bathroom if they're potty trained, making sure the daycares are aware that the child was in the emergency room with a viral infection, so that the daycares know to provide aseptic cleaning for all of the any toys, anything that's out in the open that these kids use throughout the day while they're in daycare. This spreads like wildfire in daycares. So a lot of times the daycares will shut themselves down to do a full overhaul of cleaning. Those are the 5 slides I have. So your responsibility and understanding is that education, so that we can reduce the risk factors and decrease reoccurrence. Make sure you understand that hydration status is an absolute must, and then returning to electrolyte balance with potassium and sodium. That's what I have, and that's the testable material for pediatric gastroenteritis. So go ahead and pause me for a minute while I pull up the next slide we're going to share, and that's going to be that part of my dog. All right. Yeah, my animals barking at the wind, most likely. All right, the one I'm going to do next is the overall inflammatory bowel, which is going to cover Crohn's and ulcerative colitis. Now, in your Module 3, I have a folder called Module 3 Class Collaborate Resources. So what I need you to do, we're going to open those up, and I'm going to go through the PowerPoint with you and talk about Crohn's and inflammatory bowel disease with the PowerPoint, so get that as well. This is going to take a little bit of time to discuss. So go ahead and pause me while I get my act together. All right. All right. So last Tuesday in class, we talked about the upper GI, peptic ulcer disease, cholecystitis or gallbladder disease, and pancreatitis. And we went over the functions of the stomach, the functions of the small intestine, the functions of the gallbladder, and the functions of the pancreas, and related some of the labs that are specific to the digestive process within our upper GI. So in review, the upper GI, we talked about the mechanical versus chemical digestive process. So make sure you review your labs for gallbladder and pancreatitis, or pancreas in the stomach, because with inflammatory bowel disease, this is a condition that affects the small intestine and the large intestine. And Crohn's is what we're going to talk about, I believe, first. But I want to make sure that you have a review of your labs. So again, your albumin is your assessment for dehydration. So if its levels are increased, then it's the patient's dehydrated. And then prealbumin helps great for assessing nutritional status. So when it comes to the small intestine, my point being is that with Crohn's disease specifically, the disorder of Crohn's will cause malabsorption and malnutrition, which means because of the disease process in the anatomical changes to the small intestine will prevent the body from absorbing nutrients, minerals, and vitamins. And specifically the vitamins at hand are your B12, your folate, and your folic acid related to pernicious anemia. And we're going to talk about that today as it relates to Crohn's disease. So be mindful of those pieces. You have your ALT and your AST as well, and bilirubin we talked about a little bit more in length. So what the small intestine does is it has 2 specific functions. All right, for one thing, it's longer than the large intestine, which is your bowel or your colon. So digestion, so what the small intestine does, it continues to digest food from the stomach. So your 3 segments of your small intestine are your duodenum, your jejunum, and your ileum. And that's in order, from the stomach to the duodenum, from the duodenum to the jejunum, from the jejunum to the ileum, and then the ileum attaches to the base of the right lower quadrant of your colon, which is also the right ascending. So it goes up, transverse, left lower quadrant, out. But the biggest piece of the small intestine's job is the absorption of nutrients, vitamins, minerals, water, as well as fats and carbohydrates. All right, so remember, you should have talked diabetes this past Friday with Ms. Gray. So carbohydrates are rices, potatoes, breads, that the more complex your potatoes are, the more complex your rice is, the more white your bread, your white rice, and your white potatoes, carbohydrates breaks down into sugars. So your digestive system is responsible for that process, as well as the pancreas releasing insulin to break down sugars for digestive purposes, so that the sugar is not sitting in our bloodstream, which can predispose folks to what's called type 2 diabetes, or a inadequate metabolism system. All right. So it's, hold on a minute. So that hopefully gives you some pathology or some roles of the small intestine specifically, so that you have a general idea of with Crohn's disorder what's actually happening to your folks that have malabsorption and malnutrition. So waiting for this PowerPoint to load, and hopefully the kids will go upstairs and do what they got to do. So go ahead and you can pause me. I can't stop recording because it'll just it'll capture this session only. It won't keep going on and on. While this is loading, if you go to Module 2, so Module 1 and Module 2, you have medication templates, and that means that the medications that are relevant to renal, as so for calculi, renal stones, calculi, BPH, and prostate cancer. So you have the medications, Proscar, NSAIDs, Tylenol, etc. I've gone ahead and done a voiceover that completes the table for side effects, nursing interventions, and parameters or teachings. And that's Module 1, and then Module 2 for upper GI. So when you see in Module 2 closer to where the EAQs 2 and 3 are for next Thursday, you will see that their voiceovers are there. So not only will that help you fill in the templates, it'll help kind of pull your information in for a little tighter expectation for what you need to know, and what you should be teaching at the bedside. All right, so we're going to share slides here. All right, so hopefully you also have this slide as well. All right, so a couple of things that I said earlier. In your Module 3 class collaborate resources, you open that, you'll see 3 resources in the hyperlinks. One is an irritable inflammatory bowel disorder. It's a Venn diagram. So if you pull that up, you'll be able to take notes on it. You'll see the UC and Crohn's, 2 different colors, and then in the middle it'll be like a blue sort of sphere, if you will, because there are some similarities to this disease process between Crohn's and ulcerative colitis. And I'll talk about those shortly. All right, so inflammatory bowel, it's not the same as irritable. Inflammatory means there's an inflammatory process in the small intestine or the large intestine that is causing disruption to the continuation of the digestive process. Can affect any structure along the GI tract and can be both acute and chronic. Usually the chronicity is idiopathic, which means we have no idea where it's coming from. It can arise from modifiable lifestyles. Obviously, it can be genetic. Some of the research is beginning to show that ulcerative colitis has a much more predisposition for hereditary. So if somebody in the family has a history of UC, pretty likely much higher percentage that the next family member will also be diagnosed with UC. Crohn's houses itself from the mouth all the way to the anus. But I want to clear up the muddy areas that typically Crohn's houses itself in the small intestine. So the duodenum, the jejunum, and the ileum. It has the propensity to specifically spend a lot of its time in the ileum. Okay. Yes, it can cross over into the large intestine or your bowel or your colon. But for simplicity's sake, I'm teaching Crohn's from a small intestine standpoint. And I'm teaching ulcerative colitis from a large colon perspective only. Okay. So with that being said, when you have an anti-inflammatory disorder such as Crohn's or ulcerative colitis, a lot of the concerns with the inflammatory process is the more exacerbations these folks have, the increased risk for frequency of malabsorption and frequency of malnutrition. Okay, so what that means is that our major focus is to reduce exacerbations with diet management, immunological medications, anti-inflammatory medications such as steroids, such as prednisone, which is part of our medication discussion today. So this is a little bit of that A&P I talked about. The best way is to, and I'll show you a picture here in a minute. So we talked about what the small intestine's primary role is, that's digestion and absorption. But the large intestine has two roles, and that's absorbing water and electrolytes from food that is not yet digested. So it also has the role of making sure that the body has enough fluid and that the electrolytes are balanced as well with the kidneys. And then defecation is that any waste material that is not reabsorbed, obviously, with water and food, you make stool, okay? And then it defecates accordingly. And so it's very important to understand the whole digestive process. And this kind of helps with understanding when I say cecum. So if the ileum is attaching itself to the base of your right ascending colon, that's where the cecum and the appendix are. Okay, and then you have your ascending, as I noted, your transverse, descending, and then the sigmoid colon, rectum, and anus for distal. So proximal is where the cecum starts at the right lower quadrant and works its way up to distal, which is the end. So it's when you learn it that way, it also is the functionality of how the bowel functions in its digestive process, as well as making stool. Okay. So hopefully this picture will help a little bit. So if you look at the left-hand side, the cecum, and then the ascending colon, and then you have it where you have a loop. It's sort of just a flexure. And then transverse, the left, the descending, the sigmoid, and the anus. Now, when I mentioned back in week 2 about those mechanical components of the digestive, if you look at the specific rings throughout, that is the propulsion of pulling water and electrolytes off if needed, and then making the stool as it moves through from the ascending colon to the transverse colon and out. Now, for anatomical reasons, when you see the word sigmoid and anus, this area is what's called where the colorectal cancer occurs, rectum and sigmoid. Okay, and that's what I'm going to tell you right here and now. The most important process of testing these folks is colonoscopies. Okay, so colonoscopies will go from the anus up through the rectum, up through the sigmoid, up through the descending, and all the way to the transverse, and all the way down. The colonoscopies literally will visualize the entire colon. A sigmoidoscopy is only going to go from the anus to the sigmoid section, and that is specific and not as invasive as a full colonoscopy, but both are relevant. But the sigmoid, being so specific to a very small component of your large intestine, is in fact where ulcerative colitis lives and increases the risk for colorectal cancer. So though ulcerative colitis can start all the way over here in the ascending colon and work its way all the way down, it primarily houses or lives in the rectal sigmoid component. That's where the colorectal cancer has an increased risk factor of developing because of ulcerative colitis, the inflammatory process, the continuous changes to the morphology and the cell changes that increases that risk for cancer. So hopefully that makes some good sense. Next. So it's a chronic ulcerization and inflammation of the rectum and the colon. And the location, I said, affects the large intestine and the rectum only. Okay, I'm not going to test you on the thickness or the appearance, but I want you to know it is curable. And the only way we can cure it is what's called a colectomy. Okay, the colectomy, when you think coli as your prefix, is removing the portion of the colon that has so much inflammatory process that it has to be removed because it's no longer that part of the colon can do its job. And then we make what's called, we take what's the good colon part with the other part that's good and attach it. So basically we're eliminating the portion of the colon that is so consumed with colitis and ulcers that we remove it. Okay. So you need to know the location and everything I just spoke about related to the disease of increased risk for colorectal cancer. Okay. Complications, the increased risk for hemorrhage and shock. Megacolon, when you think of the word mega, because of the inflammatory process, over time the colon itself will enlarge to accommodate the continuous inflammatory process. Bowel rupture will cause sepsis. Dehydration can cause acute kidney failure as well, but it has an increased risk for hemorrhage and shock, and I'll explain why when we get to the symptomatology. All right, so here's an example of a normal colon. So up top here, you have your person or patient on the left-hand side. And then again, you have your large colon, and inside the large colon actually is your small intestine. And then this picture here with the circle is the lumen of the colon and the sphincters that actually move all of the stool to be expelled out through the anus. Okay. Ulcerative colitis, see how much more inflamed and swollen it is throughout. And then when you look at the ulcer surface and the colon wall, it's very enlarged, it's very inflamed. And so that will persistently cause signs and symptoms that we're going to talk about. But we're going to go to Crohn's so I can show you its etiology. So Crohn's, as I said before, is an inflammation from the GI tract, so anywhere from mouth to anus. Okay. But for simplicity, pardon me, Crohn's houses itself primarily in the small intestine, specifically in the ileum. Okay. But you do need to recognize that one specific difference between the visualization of how ulcerative colitis would look like on an MRI, for example, versus how Crohn's would look like on an MRI is the appearances or patches of inflammation called cobblestone. Okay. So when I teach you cobblestone, think Crohn's disease. So if you ever think of a cobblestone road or a pathway, You also can Google images and look at Crohn's disease. It's a cobblestone appearances versus, let me go back a couple, where you have here the ulcerative surface is more of an inflammation and doesn't have cobblestones. All right. So with here's a normal intestine on the left-hand side, normal wall, normal surface area. But if you go over here on the outside of this lining, that's the cobblestone-like appearance, like a walkway with cobblestones on it. All right, so that's very specifically going to look different on visualization than ulcerative colitis. So the complications, the cure, there is no cure for Crohn's. So let me say that again, there's no cure. So we can cure ulcerative colitis with a colectomy, but we cannot cure Crohn's disease. So it's incredibly important. Well, they're both very important, but with Crohn's disease, managing diet, lifestyle, and anti-inflammatory medications to reduce exacerbations of the disease is the primary goal of Crohn's, because there's no cure. There is surgery, but I mean, we can do an ileostomy. So as I said, if Crohn's disease specifically houses in the ileum, and the ileum is so destroyed by the Crohn's disease, we can give them an ileostomy. Now, think about the kind of output that ileostomy, that's your small intestine chronically putting out electrolytes, water, minerals, vitamins, etc. So these folks are always at risk for malabsorption, malnutrition, chronic weight loss, etc., etc., etc. And that bag is not reversible. They're living with that. And that loose, watery stool puts them at increased risk for skin excoriation to the peristomal area, frequent changing of bags, body image disturbance. So it's I think the best way to explain it is, let's manage the Crohn's disease from a lifestyle and a pharmacological management, okay? Complications with Crohn's disease is abscesses and fistulas. So make sure you understand what a fistula is and an abscess is. Whereas with ulcerative colitis, you have bowel perforation, you have increased risk for hemorrhage, which is bleeding, which can cause septic shock, because you lose blood, you lose volume, and you have a cardiovascular event. So what I'm going to do next is we're going to look at ulcerative colitis and Crohn's side by side, okay? And this is where your Venn diagram continues to be helpful for you. So, my bad. All right. So the presentations of UC, okay? We have edema with both, okay? As I said, I'm not going to have you necessarily make sure, well, I want you to be able to understand the inflammatory process and the location of UC. As I said, the rectum and the rectoid sigmoid. Severe cases can affect the whole colon, and we can have B12 deficiency, and that's called pernicious anemia, where the patient would need B12 injections. Because remember, when you're looking at absorption as part of the job of the large intestine, and that's to reabsorb water and electrolytes, nutrients, vitamins, and minerals. So even though you might see more of a pernicious anemic state with someone with Crohn's disease, it still can have the same type of outcome with someone with a diagnosis of ulcerative colitis. There is staging. We can stage ulcerative colitis. That is a process of the more severe the exacerbations are, the more frequent the exacerbations are, that increases the severity of the disease process, and therefore that's when we start looking at surgical interventions such as the colectomy I spoke of. Presentations of Crohn's anywhere along the GI tract, as I said, mouth to anus, any part of the bowel. So you'll hear the word small intestine, small bowel. Those are your that's your small intestine. So you got different lingos, different language. Make sure you're able to clearly understand the difference. Fistulas are common with Crohn's as well as abscesses, but because of Crohn's managing specifically the digestive absorption and nutrients, it has, of course, that increased risk. And as I said, the ileum is more involved, but jejunum also as well. And remember, your duodenum is going to have more of an effect with duodenal ulcers. And then the B12 injections are applicable for both. All right, so clinical side effects or signs and symptoms. So these are risk factors. Both are genetic predisposition. UC is becoming more and more of a genetic predisposition. They have done a lot of research to say that UC is higher among Caucasians and Crohn's is more higher amongst Jewish heritage. Ulcerative colitis, if it's going to be a predisposition, your teenagers are going to be diagnosed early on in life and more often in females. For men, it will be more older adulthood. So your female teenagers most likely will develop ulcerative colitis from genetic predisposition. Now, what's important for you to understand is the process of what's causing the output. And so you're not going to see a patient with UC or Crohn's have an incidence of nausea and vomiting. Okay, this is a management of nutrition, of all I've said before, and electrolytes, fluids, etc. So the output is going to be in a diarrhea-like state. Ulcerative colitis is anywhere from 5 to 30 stools per day with blood and mucus. Can you imagine someone losing that kind of volume of potassium, fluids, and then blood? So that's driving back the hemorrhage risk factors. So you're automatically looking at a Maslow of circulation. You're looking at your labs for H&H. You're looking at your red blood cell counts, etc. All right. This is not an infectious state. So these folks, when you think about pharmacological, we would want to stop the diarrhea because it's not virally driven. Okay. Crohn's, as I said, typically are teenagers 15 to 30, but you have a higher incidence of modifiable risk factors of tobacco use and red meat consumption. Your periods of remission and chronic, again, the long-term goal is to reduce exacerbations and have longer remission time. Okay, diarrhea is common with Crohn's, but not as severe as UC. All right, so you don't have blood or mucus in the stool, but you do have diarrhea. So make sure on your Venn diagram that you specifically understand the diarrhea presentation component between the two. All right, some other things in sense of signs and symptoms. Abdominal pain for UC, but remember when I said ulcerative colitis tends to live in the left lower quadrant? So they'll have pain and cramping, but it was going to be relieved with defecation. All right. They will have anorexia, they will have weight loss, they will be anemic, and hypoalbuminemia. So it's not pre, so it's al, so they're going to be dehydrated because 30 stools a day of loss of electrolytes, loss of fluid, and blood loss. Okay, so if you understand what I said before about the location and the location of ulcerative colitis, that it would make sense that that abdominal pain on presentation would be at the left lower quadrant. Crohn's, on the other hand, we can have cramping and or steady pain in the right lower quadrant because I said it's more housed within the ileum. In the your belly button under tenderness there may be a mass there, but that's a much more provider-driven assessment, but could be a lot of different things. I'm holding you to location for UC versus Crohn's, presentation of the diarrhea between UC and Crohn's, and understanding the malabsorption is more weighted with Crohn's than it is with UC, but you're looking at pernicious anemia across the board for both. But you can see a significant loss of multivitamins and mineral deficits, and you have weight loss and anemia with both. So what labs are you going to look at? We already talked about pre-albumin, so that's going to be nutrition. So you expect it to be severely elevated with someone with Crohn's. Albumin most likely will be, obviously it's not most likely, will be elevated with UC because of the amount of diarrhea per day. So it's helpful that way as well. So clinical side-by-side physical assessment findings. So as I noted, you tell me what we're going to have. So this is your Venn diagram, which hopefully will be helpful for you. All right. Physical assessments, you're going to have where's your pain going to be located for UC? How is it relieved? With Crohn's, where is the pain located? What labs would be particular to UC and Crohn's? So we talk about albumin, pre-albumin. UC, you're probably going to see a much low H&H. They're probably going to type and cross-match these folks for blood transfusions. They should be anemic, so they would do a B12 blood work, and so you would see B12, folate, folic acid would all be on the low side. So we're going to talk about pernicious anemia and what kind of side effects or clinical manifestations you expect your patient to present with. So I know you can't see me, but you can hear me. So pernicious anemia, these folks are walking around with low H&H. So they're going to be lethargic, fatigued, tired. They can be short of breath with activity because I'm lacking oxygen in my red blood cells. Vital signs, you expect them to be tachycardic, low blood pressure because of low blood volume. I would expect pulse ox potentially could be on the lower side. And if you look at your, in the pancreatitis PowerPoint, there is an entire PowerPoint slide on signs and symptoms of how a patient would present in a pernicious anemic state, and you do need to know how your patient's going to present. Remember when I said that the gut or your abdomen's a poor historian? So this is an incredible amount of work that the providers have to go through to figure out what in fact is causing the patient's abdominal distress, if you will. Okay, so talked about labs, and so make sure that you're familiar with those. So diagnostic procedures, as I mentioned before, in order to show you the anatomy of where ulcerative colitis hides. So if you're looking here, your colonoscopy, it's going to be the entire colon. So it's the entire length of your colon. So where it has the end of the sigmoidoscopy, if you look at the green line, so that's from your anus, the rectum, and then the sigmoid. So the sigmoidoscopy is specific just to that region, where colonoscopy, as you can see, is the entire visualization and length of colon. So the bottom line is the CDC, or the Centers for Disease Control, are very specific about at what age colonoscopies are considered preventive medicine. In other words, the insurance will pay for it. And so 50 years and older, unless there's a pre-existing condition, so ulcerative colitis. So one of the ways we talk about prostate cancer was the incidence of family history. So the incidence here of a family history of ulcerative colitis. So I have a dad, male, 45, smoker, consumes a lot of red meat, starts having defecation issues, and goes in for a colonoscopy, okay, and is diagnosed with ulcerative colitis. They will backpedal on any males and or females in the family to start this diagnostic procedures younger, because you have a pre-existing family history of it. And so the whole point, again, is that you want to ensure that we have a longer period of remission with decreases of exacerbations, because the more acute exacerbations you have, the more destruction is happening. And remember, Crohn's is not curable. All right, it's not curable. And I wouldn't want someone with ulcerative colitis who we are pharmacologically not doing what we need to do non-invasively with diet, exercise, modifiable lifestyle changes, and end up having that person with a permanent colectomy. Okay. So with that being said, some of your diagnostic procedures, we can do the MRIs with the visualization, something like your ERCP, but it's actually looking at your colon. It looks at detailed images of the organs. So client education, again, most likely these folks would be NPO. Your allergies, again, with your contrast dye for allergies to iodine and or shellfish. Here's your diagnostic procedures. So the sigmoidoscopy and the colonoscopy, I think I've talked about at length. The stool examination is necessary just to rule out, for example, what if it is bacterial in essence, or we don't have visible blood, so we would look for hidden blood. CAT scans, MRIs, barium enema, what is it? And I wish we had class time, but what is a barium enema? So I'll grab my little cell phone. You go kind of watch me Google, because I would tell you to Google. I mean, I know what it is, but I want you to tell me what it is, but we really can't in the moment. My Google. So what is a barium enema? Besides the fact that it's an enema. All right, it's a special X-ray of the large intestine, specifically colon and rectum, that uses a contrast liquid called barium to highlight abnormality like polyps, inflammation, or blockages. And it's filling the bowel with a tube inserted into the rectum. And it coats the intestinal lining and making it appear white, and then allows the doctors to look at bleeding, inflammatory bowel diverticulosis, and even colon cancer. Okay. So it's a step up from a colonoscopy. Okay. It's a step up from a sigmoid. It's sort of added on. But this barium sulfate will do those things. And so there and hence is why your colonoscopies and or your sigmoidoscopies are so absolutely critical in assessing your patients who have underlying inflammatory bowel disease, specifically UC. Crohn's, on the other hand, is going to be an endoscopy, because if it starts in the mouth and tends to end at the ileum, an endoscopy is a great way to say and see if those cobblestone patches actually exist. You have the abdominal ultrasound, you have the X-ray and the CAT scan. And again, remember I said Crohn's can also go all the way to the anus. So there's another example of where the barium enema can come into play to show, if relevant, those cobblestone appearances. So diagnostic outcomes, usually because of the inflammatory changes and the ulcerations in UC, you see the specific changes to the structure formation of the sigmoid colon and the rectum. And with Crohn's, you have the narrowing of the small intestine. So the narrowing, you start thinking strictures, fistulas, and abscesses, whereas the inflammation is where that megacolon component comes in and that bowel perforation comes into play. All right. So as I said, our goal pharmacologically is we're going to look at some modifiable changes. Stop the acute attack as quickly as we possibly can. And this reduces those incidences of relapses. As I mentioned before, I can't stress it enough. So for medications, all right. So folks are on long-term anti-inflammatory type agencies. These page numbers are not relevant to Elsevier. But when your patients are in the hospital, part of your medication template from module 2 covers prednisone. And so that is the medication I'm holding you accountable for from a teaching, education, hospital bedside practice, and it's testable material. So these folks can be on corticosteroids such as prednisone to decrease the inflammation. Typically, folks are not on long-term prednisone because of the long-term side effects. Can exacerbate type 2 diabetics, can cause hyperglycemia, can cause skin changes over time where it can thin out the skin, increasing risk for skin tears, especially in your elderly patients. So it's long-term effects. It's not a good drug to be on long-term, but short-term management at the bedside to reduce the inflammatory process that's occurring, absolutely. So what these folks are on long-term is TNF inhibitors and immunodulators. And what that is, I think if you've heard about Humira, but these are long-term biologic anti-inflammatory medications. They can be given on a quarterly basis of injectables, such as Humira that's used for rheumatoid arthritis. Anybody with a long-term chronic inflammatory disorder, such as rheumatoid, lupus, and inflammatory bowel disease, will be on these long-term, because what happens is that it's reducing the body's need to, it reduces inflammation. And that's the whole point, is so that the colon and the small intestine can do their jobs without an inflammatory process flaring up. But when you have these people on this type of medication, it's reducing the body's ability to have good immunity. So what's happening is that the people are at higher risk for opportunistic infections and should be taught to wear masks in public and crowded environments to make sure they stay current with their vaccines, such as their COVID vaccine, get their RSV vaccine, because RSV is no longer a pediatric disease, or I should say a viral infection that affects the respiratory system. It is highly problematic for causing pneumonia in older adults, as well as causing RSV in older adults. So the flu vaccine, RSV, and pneumonia. So stay on top of your folks that are on these immuno medications to keep exacerbations to a minimum. Okay. So those are really important pieces as well. So washing hands, wearing gloves, wearing masks, try to stay away from crowded environments. If you're sick, stay home. Washing fruits and vegetables. It just increases the risk for these patients. The common cold can turn into pneumonia, for example. So that's the teaching component that I want to make sure that you understand, because what you're going to see when a patient comes in an exacerbation is these long-term biological medications that are going to be on their home medication list. That's going to tell you where your education needs to start. Are they taking their medication as directed? Are they wearing masks when they go out in the public, et cetera, et cetera? So you can see hopefully how I'm connecting those pieces. Antidiarrheals I did mention, and they will be ordered, such as Imodium, or for getting the diarrhea to slow down. So the other piece of it is, if in fact, when I mentioned the stool culture before, if we want to rule out bacterial GI gastroenteritis in adults, and there's no history of UC or Crohn's, again, it could be your female teenager, or it could be your middle-aged adult male. So again, somebody with a new onset, new diagnosis, we're going to rule out the fact that it's not bacterial. Okay, so we're going to look at iron levels based on lab results. So ferrous sulfate is an iron medication, typically one of the ones I have yet to mention. Ferrous sulfate's ugly on the body. Can be given by mouth, can be an oral suspension, but it has to be taken on an empty stomach. You can take it with orange juice or water. Orange juice will help with the absorption of the ferrous sulfate. It can be also taken with vitamin C to improve absorption. The best way to take it is on an empty stomach, but it causes, on more patients than not, severe indigestion, nausea, and vomiting. Sometimes these folks can't tolerate it on any form and end up needing IV transfusions of iron, if it's that bad. Will cause severe constipation and will turn stools black and tarry and sticky. Now, tarry stools can also represent hidden blood in stool. So just make note of that when you're educating your patients, that their stools, they're already having bleeding episodes, right? And if they have black tarry stools, they may have been told at some point in time that that may be blood in the stool they can't see. So please make sure that you're teaching them that if they're on ferrous sulfate, that's the expectation. And if they're having constipation, increased fluids, stool softeners are much better than other types of medications, such as, I'm not going to get it. Miralax is really good for constipation. I'll think about it and see if it'll come back to me. What I was trying to get at, laxatives. Encourage you folks not to use laxatives like Dulcolax, because stool softeners are the best thing, because high fiber foods will make bulk and will help promote regularity. So the softener of the stool softener will soften the stool to help reduce the discomfort or defecation of hard stool secondary to, say, ferrous sulfate. When you add Dulcolax, that's a laxative. Your bowels will become dependent, and eventually enough Dulcolax over time, the bowels will stop working without the Dulcolax. So that's why we don't encourage any type of laxative use, because of bowel dependency. All right. So iron preparations. I talk about this in the next slide. I'm really going to test you on pernicious anemia, so that you have a better understanding. Of why the malabsorption of iron specifically in Crohn's disease, and the function that iron has on brain metabolism, the lethargy it can cause, brain fog, lack of concentration, lack of focus, unsteady gait. It has a big deal with neuromuscular activity. So vitamin B12 typically is given as an IM injection in the deltoid. So part of making sure that we understand. So open up your staff rep through the library, and make sure that you cover these pieces of this PowerPoint slide. And hopefully we'll have class on Tuesday, face-to-face. If not, we'll go over this in more detail. Folic acid and sources of iron. Now, sources of iron, there's tons of it in our food, especially our dark green leafy vegetables like spinach, beef, potatoes, tomatoes, lots of meats and seafood, oysters, sardines, poultry, chickens, huge, fortified breakfast cereals, high sources of iron as well. So getting at what your folks are eating is also very important. But here's, like we said, red blood cells carry oxygen and iron. So it's essential to the functioning of our bodies, because it helps restoring and transporting oxygen. And with formation of hormones, I mentioned the nervous system, I mentioned, and sense of brain fog. So we have to be really on the stick when we think about this component when it comes to Crohn's disease specifically. And malnutrition, you would see elevated prealbumin levels with that as well. Something else I was going to mention, but it's not happening. All right, so TPN is total parenteral nutrition, and I didn't bring it up with pancreatitis because I'm going to feed it back into pancreatitis. Usually chronic pancreatitis, because acute is usually gallstone driven and can be resolved when we get rid of the gallstone. But chronic pancreatitis, we know either viral or long-term alcohol drug use, where the pancreas is in a necrotizing state. Necrotizing means it's eating itself to the point that your pancreas doesn't have the enzymes of amylase, lipase, and pancrease to break down sugars, carbs, and protein. And then we might have a complete destruction of your beta cells for insulin production and release. So TPN can be a long-term enteral feedings. And so it is a PICC line, it's not a peripheral line, and PICC lines are put in by trained staff and or providers. This is, as I said, they either physically can or psychologically can't consume nutrients. We'll always do a chest x-ray to make sure the PICC line's in a central vein. And based on labs, usually it's a 2,000 ml bag of nutrients, vitamins, B12, folic acid, ferrous sulfate, irons, glucose, carbohydrates, proteins, fats such as lipids, are made in a concoction that hangs for 24 hours on an IV pump. And that's how we're feeding our patients. That's their liquid nutrient, or banana boats, sometimes people call them. It's not a good thing because some people might end up living on TPN. So to kind of go back in a circle a little bit, so TPN can also be used for someone who's in severe Crohn's because there's no cure, okay? But TPN is through the PICC line, and that can be a long-term use. With your NG tubes, we talk specifically about dropping an NG tube for low wall suction for peptic ulcer disease, pancreatitis, gallbladder disease, etc. But that's a short-term usage. You can also do tube feeds through an NG tube, but that's short-term. This is a long-term possible solution on the fact that the GI tract is no longer functioning and may not return, and it may be permanent. There was a patient on 3-VPN on Friday, for example, who has been in the hospital for over 4 months and has been on TPN for 4 months for necrotizing pancreatitis. Composition I spoke to, indications I spoke to, nursing actions. Let me go to the next slide. Nursing actions. So our job with TPN is, because of the destruction to the pancreas long term, we have to check these patients' blood sugars because they're going to be potentially in a hyperglycemic state, and especially if they're getting glucose as part of the quote unquote TPN makeup. Now, the makeup of the TPN is done by dietitians. All right, it's not by the nurses, not by the providers. So labs are drawn usually, I'm going to say 3, 4, 5 a.m. in the morning, specifically to TPN needs, and the dietitian is going to look at the lab results, and she, he, they is going to determine what the next bag, if you will, of concoction is going to be based on how well that current bag that's hanging is helping with lipid, proteins, carbs, glucose, your iron family, etc. And then we'll hang the next bag. If your patient can come off the TPN, it has to be a very slow transition. That means that we don't just abruptly stop the TPN. That's going to rebound hyperglycemic patients, and that can put them in a DKA state. So as we're slowing the TPN and transitioning them down and reintroducing oral nutrients, it's going to be in a clear liquid form, just like a post-surgical patient, and see how they tolerate. We're constantly checking blood sugars and supplementing regular insulin, and or if they got to be on Lantus, etc., for whatever, if they're in a really bad state and the pancreas just isn't producing insulin anymore. So be mindful of our jobs and making sure we're checking blood sugars as ordered. And as I said with pancreatitis last week, you should have a sliding scale in a patient's MAR, and we should be checking sugars based on provider order. Or if your patient's presenting in a hyperglycemic state, which is slow and insidious, polyuria, polydipsia, and you tell me the third one. So we have itchy skin, increased thirst, and increased urination, okay? So hyperglycemic is very insidious, and that word means that it comes on very slowly. As you learned, hypoglycemic is a very fast drop in blood sugar and pretty acute in sense of symptomatology. So the surgical side of things we talked about is necessitated if all of our non-modifiable pharmacological therapy options are we're at a last resort. So with Crohn's disease, I said there's no cure, but the physicians will do what they have to do. It's pretty ugly. Abscesses and fistulas are conduits that are as the narrowing and strictures of your Crohn's disease. They will, I wouldn't say rupture, but they will divert to another offshoot. So fistulas are things that are full of pus and bacteria that we end up doing wound care on. Patients can have wound vacs. Abscesses, I know, are those enclosed pods full of fluid and bacteria and pus. So Crohn's is just really ugly, which is why we can't stress enough the value of, I hate the word compliance, but understanding the severity of maintaining compliance, because the end result is not good. We talked about the colectomy for ulcerative colitis. I talked about the ileostomy as it manages frequent liquid stools because of its location. I don't know how much of colostomy care or ileostomy care that you had in 111, but know that you're diverting a portion of either the small intestine or the large intestine by pulling it to the top of the abdomen wall and creating a stoma. So the stoma is actually the intestine, whatever part it is, and then we're capturing output, whatever it is, whether it's from the ileum or from the colon being stool, ileum being nutrients, and then teaching your patient how to manage that. And then you got lifestyle issues, body image, sexual disturbance, more malabsorption, more malnutrition with Crohn's, with the colectomy for the UC, most likely permanent. If there's not a lot of damage, that may be reversible over time with a reduction in inflammatory process. I'm not spending a whole lot of time on the non-pharmacological. I should, but increasing dietary fiber will limit exacerbation. So the takeaway from the dietary standpoint for modifiable, for folks with either UC or Crohn's, they want to increase their dietary fiber intake during remissions. Okay, they will not be on a high fiber, low fat diet during an exacerbation. Okay, so they should be on a high fiber, low fat diet in normal circumstances, and then we'll minimize the fiber while we're treating the exacerbation. As I mentioned with the TPN, if they're having acute exacerbation of Crohn's, they're not absorbing anything, so we might just put them on TPN. Or drop an NG tube and do enteral tube feeds until it depends on the severity of the exacerbation. Intestinal strictures are specific to Crohn's, whereas that megacolon is specific to UC. Probiotics, we talked about that. I think a student mentioned probiotic use. Sure, there's no reason to say it's not a good idea. As you get more clinical experience with 114 and 112 and actually get into the meds as part of your objective assessment data, you'll see a lot of lactobacillus on patients' MAR, and that's because of stress level and or GI disorders to help maintain normal bacterial flora. Herbal supplements, I mean, that's just there's certain things when we talk mental health and cardiac that should never be used with mental health or cardiac meds, but there's no real research out there that supports the functionality of how well it works. And we don't have, it's not research through the FDA. So we don't know if, we know some medications can decrease efficacy or increase efficacy in some of our mental health meds and our cardiac meds. But, you know, we don't typically encourage it. But when you're reconciling patients' home medications, it's important to pick up on the fact that it's just not prescribed meds. It should be also over the counter, as well as any alternative complementary meds like St. John's wort is a big one. Saw palmetto is a big one, etc. Cognitive behavioral therapy, we talk about that at length with mental health, and some of this will come back because, as I alluded to last week, with the gut being your second brain, a lot of our neurotransmitters, our dopamines, norepinephrine, serotonin, live in our bowel. So a lot of times folks with mental health disorders, chronic severe depression and or anxiety, bipolar disorder, major depressive disorder, have significant GI issues throughout their lifetime, whether they're properly pharmacologically managed mental health wise or not. So you can look at those pieces as well. As I said, Crohn's is more common in males. If you're going to have Crohn's disease, go back to the very first slide with the onset with females in their teens. I'm not testing you so much on that, but it's important to get at it, especially with your anorexic and bipolar females, because that's particularly where it hits mental health wise. The exacerbation of Crohn's is more common. I don't really talk a lot about the pediatric inflammatory bowel disease. Our focus really is on the pediatric gastroenteritis from a viral etiology standpoint. It's it's going to be picked up pretty early on in the pediatrics because with breast milk or bottle feeds, it's because of the dairy or the breast milk hormones, that's where we would see it. And there's an analogy, for example, babies born with congenital heart defects, a hole in the heart, poor valves, etc. It's like a broken heart at birth, whereas congestive heart failure is a broken heart later in life. So this is an example of pediatric inflammatory bowel disease, so a broken gut at birth, if you will. Lifespan considerations. What interesting factor on this particular side is celiac disease. It's only probably been in the last 15 years that celiac disease basically means people are allergic to gluten, which exists in most of our carbohydrate type foods. But people with celiac disease tend to be of short stature, short hands, and short length of their feet. But what it is because nobody knew that they had an allergy to gluten. So as they're growing up as children, their skeletal structure was stunted as a result of their allergies to gluten. And it wasn't like they were having like nausea and vomiting per se, but it was stunting their physical height and their physical growth. And because of the research that's come out now, these adults that are 5'4", shoe sizes, maybe, a pediatric 6, for example, have celiac disease. So it's be mindful of that in the sense of it's becoming much more prevalent because now we're understanding the connection between gluten diet and celiac disease. So, and then of course, unfortunately, people not adhering to management of medications and/or lifestyle adjustments. Pregnant women, because of the genetic predisposition, it's helpful to have genetic testing, especially if it runs in the family, or the biological pregnant mom, already has Crohn's, let's say, for example, and is on Humira or some type of TNF inhibitor, might have to go off the medication for a period of time before conceiving. So just if you're going to go into labor and delivery, we need to, that's part of our teaching with moms, especially if you're working with that population of women. And then, of course, some of these medications are going to be contraindicated with breastfeeding because they will cross the barriers. So here's some of the similarities that can kind of capture these PowerPoint particularly as well. So you can use the Venn diagram for that. And then here's your similarities for the blue component within that. Prevention, I think I've talked about at length. It's going to be pretty much the same throughout that we talk about in our discussion of the body. So review that. You will also see in your Module 3 class collaborate resources, I have a case study on UC and Crohn's, and I have a clinical manifestation presentation between UC and Crohn's. So please complete those, because if we do not have face-to-face on Tuesday, we will be meeting for a Q&A for this content. So having the completion of the case study and the information sheet will make sure that you are tracking accordingly. And that's going to be very helpful as your study guides. And the last part of that you are amazing human beings. So go ahead and take a break, but I'm going to keep going because our last piece of content is going to be on glomerular nephritis, acute versus chronic. And that PowerPoint slide is in Module 3. here comes the kitties, children. Hello, loved ones. Yes, I hear you. Pardon me. All right, share now. It's all right, dear. You're on candid camera. I know. Go ahead. All right, last but not least is acute glomerular nephritis. So there's a couple schools of thought of why I made this in module 3, because the glomerular nephritis is the glomerulus within both your kidneys at the flank left and right of your lower back. And the glomerular is what manages the filtration of waste products and manages your sodium and potassium pump. But it's an inflammatory reaction, which is an acute etiology, or it's a chronic etiology, chronic glomerular nephritis secondary to chronic autoimmune disorders. So it's a matter of kind of looking at it from an inflammatory process, but it's affecting the kidneys. So I've housed it in module 3. So if you have access to that, please go ahead and pull that up. So let's just go back to your renal labs to make sure that we're still tracking. So you got your BUN, which is managing the excretion of urea and nitrogen out of your blood. And then you have your creatinine levels, which is your biggest indicator for dehydration of a patient, because that is the process of your kidneys getting rid of muscle waste. So the best indicator between your BUN and the creatinine for dehydration or kidney injury is your creatinine level. Your CBC, of course, with anything inflammatory can have an elevated white blood cell count. And then if the providers are doing CBCs with differentials, so your CBC typically houses your white blood cells, your RBCs, your H&H, and your platelets, and then your morphology of the MDCVs and the MDCWs, etc. So basically with the white blood cell line item, you're just going to get whatever it is, let's say 8,000, which isn't within normal limits, no infection. But if the provider is concerned about an infection, they may do a differential, which takes that white blood cell and now does align items with neutrophils, leukocytes, eosinophils, basophils, monocytes. And that is what I call the white blood cell army. So the army that fights the infections in your body. The differential is helpful to recognize whether I'm dealing with a new infection, new neutrophils, or I'm dealing with an old infection that's exacerbated, and that's your leukocytes. So again, your complete blood count is going to give you a white blood cell line item. If the provider wants to see whether it's a new infection or an old infection, they'll do what's called a CBC with differential. Now, Ms. Grace will talk more about a CBC with differential as it relates to appendicitis. But that's important to recognize when we're looking at inflammatory disorders, which is everything we've talked about from module 1, 2, and 3, but I'm bringing it back as it relates to the kidneys with glomerular nephritis. Okay, so stay with me, stay tracking. So when we think about, let me just move along the PowerPoints a little bit. Let's see, there we go. Nephritis, objectives, overview. All right, so nephritis. So let's look at the prefix of the word nephrons. All right, nephrons within the glomulus of the kidneys. Okay, the job of ensuring that the kidneys are creating and excreting and eliminating the stuff our body doesn't eat. So it's an inflammation of the kidneys. There are two types. One's acute and one's chronic. The acute post-infectious glomerular nephritis is related to strep throat. Okay, the pathology or the reason behind acute glomerular nephritis is untreated strep. When I say untreated strep throat, now I want you to think about your populations that have strep throat: teenagers, kids, sometimes adults, right? They will go on at least a 10 to 14 day treatment of penicillins to eradicate or get rid of the strep throat. Okay. So after that 14-day course of treatment, what's happening here is that the kidneys, those antibodies that the immune system is responding to, is causing those antibodies to get lodged inside of your nephrons. And so you may say the word lodged, an obstruction. Yes, to some degree it is an obstruction, but it's causing an inflammatory reaction and scarring. So basically what's happening is your nephrons are not completing the job of that wet bed, which was that acronym I showed you on day one. So the acid-base balance, the electrolyte balance, the water balance, etc. Tracking? So the folks are going to have a lower GFR. So when you look at your basic metabolic panel, the basic metabolic panel, or BMP, is going to give you your electrolytes of potassium, sodium, and I believe phosphorus, calcium, platelets. I think platelets will be with the CBC, but it's going to give you kidney function, okay? And that's where your BUN creatinine is, and below that line item, you're going to see the GFR. And so greater than the greater sign GFR and then greater than 60 tells you that you have adequate excretion of urinary waste products. With acute strep throat or acute glomerular nephritis, you're going to have a GFR on the low side because of that inflammation is preventing your kidneys from themselves being able to get rid of waste products. All right. It's not the strep, it's not the strep infection itself that's causing the inflammatory reaction. It's sort of like the antibodies of what our body is fighting against, it just kind of goes wacky and gets, those antibodies get stuck inside the kidneys itself, and it causes inflammation and damages the glomulars. And let's just leave it. I'm not testing you on the pathology of it. I'm letting you know that the acute component is due to untreated strep. Or they've been on antibiotics for 14 days and they're having a reaction to that antigen antibody complex that goes on. Hold on 2 seconds. All right. Come on. Come on. All right. So remember when we talked about what a urinalysis should look like in a normal adult, okay? We said a normal pH. We said they should not have any red blood cells. They should not have any protein. They should not have any glucose. They should not have any leukocytes. They should not have any bilirubin, and they should not have any white blood cells. Their urinalysis is going to light up like a Christmas tree, okay? They're going to have blood in their urine, all right? They're going to have excessive protein in their urine, and that's going to make the urine look tea-colored, TEA, as in a cup of tea, all right? That's called azotemia. A, Z as in zebra, O, T as in Tom, E, M as in Michael, I, A. All right, azotemia. So when you see that word, that means that person has excessive like nitrogen waste in their urine. And so that is tea colored or Coca-Cola colored, okay? And then the hematuria is the blood in the urine. They'll have proteinuria, and so you'll see some spilling of protein. They're going to have poor urinary output because of the inflammation, okay? So that means because of the inflammation, they're going to hold on to water and they're going to hold on to sodium, okay? So they're going to be hypernatremic, all right? And they're going to be a low albumin for dehydration, all right? But by retaining sodium and retaining fluid, these folks are going to be edematous. The key feature of the edema is first thing in the morning, facial swelling. Okay, this is not angioedema from medication. This is facial swollen face. Okay, they'll have elevated blood pressure because they're holding on to fluid. All right, they'll have a headache because of the increased volume. They're going to be tired and fatigued because they're holding on to sodium and fluid, and they'll have an elevated BUN and creatinine level. Okay, so what do you think we're going to do to fix it? They're going to come into the ED and they're going to have a swollen face. All right, this is not congestive heart failure. Okay, Well, when we determine it's from antibiotics that didn't clear up the strep throat, we're going to put them back on antibiotics to clean up the strep and the antibodies from. So we're going to fix the cause. So they're going to go back on penicillin. If they're allergic to it, they'll go on a cephalosporin backup first generation medication. That's how we fix the infection that's caused the acute glomerulonephritis. But how do we get rid of the fluid and the sodium? Diet restriction, so decrease sodium intake. They're not going to have IV fluids running, all right? Decreasing the protein in their diet, okay? And then providing lots of carbohydrates, because carbohydrates will stop the breakdown of protein, for starters. And they need the carbohydrates for energy. And basically that's what we're going to do. So they're not going to be NPO. We're going to put them on fluids. We're not going to put them on fluids, and we're going to reduce the sodium. And that's in the acute phase. So carbohydrates will provide the energy, fluid restriction, sodium restriction. So, but where's your baseline? So if these full of fluid, what do you want to do? So as you're starting to put your interventions into place, what is that going to begin to look like? So here's some of the examples for that as well. And I'll get into chronic in a minute. You want to monitor daily intake and output. So they're going to be on strict INOs. You want to weigh them daily. Okay. These people will be hospitalized for a period of time until their kidney function on labs comes back, because we want to make sure that the worst case scenario is that we don't lose the kidney function, and that we reverse the hydration and return the sodium levels to normal. So the biggest thing here is daily weights, and then strict INOs, and making sure they're on an antibiotic, which is usually your penicillin. Now, students get caught a lot of times with which comes first, second, and third. The first thing you're going to do is treat the strep, because if you don't treat the strep, then they're going to continue to hold on to fluid and they're going to continue to hold on to sodium. Your priority is to treat the strep throat. Then you have strict INOs, so fluid restriction, sodium restriction, and the daily weights is first thing in the morning in their birthday suit. You want a dry weight, so make sure they urinate if they can. Okay, so remember your kilos to pounds and your pharmacology conversion component. So 2.2 pounds equals a kilo, or 2.2 kilos equals a pound. So make sure that you're going to be tested on that, but usually your conversions in the hospital either pounds to kilos. So it's important to get a baseline weight when they get admitted, so that when you look at your fluid restriction intervention, you look at your sodium restriction intervention, they should start having water weight loss, okay, especially treating them with that antibiotic, which is your specifically primary job. Because if we do not treat, then you risk losing kidney function, and that puts them on dialysis. And this is going to be more relevant to the chronic component that we'll talk about shortly. So that's the presentation for acute glomerulonephritis, with the underlying etiology is unresolved strep throat, or the antibiotics from the treatment of strep has not worked, or have the autoimmune response between the antigens and the antibodies, and it's because your kidneys excrete and eliminate, so it's getting that component gets stuck and lodges within the tubules of the nephrons. Boom, you end up with them coming in first thing in the morning with swollen face, all right, because they're laying flat during the night. So think about, again, the interventions: fluid restriction, sodium restriction. We're going to increase the carbohydrates for energy, for minimizing protein breakdown, and then obviously the medication for the treatment of strep throat. As I said, signs and symptoms: they'll have hematuria, they'll have tea-colored urine from nitrogen waste, they're going to be sluggish, kind of feel crappy, malaise, they'll have a headache secondary to increased volume, therefore increased blood pressure would be a result of that, and increased BUN and creatinine. Okay. Chronic glomerulonephritis, on the other hand, is a direct result typically of autoimmune diseases such as lupus, is usually the primary one. Multiple sclerosis, not as much. You learn about lupus and you learn about multiple sclerosis in 211. But lupus is an autoimmune disease. So autoimmune disease basically says that the kidneys, which we have a part of our life, but the body doesn't recognize it as a friendly entity. It's an enemy. So it begins to battle itself. And so somebody with lupus will automatically be a risk for chronic glomerulonephritis. And what's happening is that the body's fighting the functions of the kidneys. So it's progressive, it's slow. Lupus, it's chronic. It's because you have lupus, you're going to have lupus nephritis at some point during this autoimmune disease of lupus. So as the manifestations, your manifestation presentation is the same exactly as it is for acute. Your signs and symptoms are exactly the same as acute. The problem with this is that it's chronic. So yet again, our job is to reduce exacerbations and have longer remission times, which is saving kidney function over time. Glomerulonephritis, for again, it's lupus driven. Diabetes will certainly play a role, but unless your patient's lupus with diabetes, it's a double entity or it's a double problem. There's some other risk factors, family history, which would be lupus driven, hypertension, because your kidneys manage hypertension, as well as your cardiac muscle manages hypertension. I'm really focusing more on the lupus as the primary etiology, just so you're aware of that piece of it. It's not necessarily, I usually just fall back on the fact that someone has lupus and they have really crappy kidney labs, and then they're most likely going to show with lupus, and then the insult of adding diabetes or family history or hypertension or all of the above can also lend its fact to the poor kidney function secondary to chronic. So you can see where if it's diabetic, management is appropriate, blood pressure medication is appropriate. Now, if in fact it's hypertensive driven and the patient also has lupus, they will not be on ACE inhibitors because the kidneys are already struggle busing to work in the first place. So the blood pressure control is going to either come from calcium channel blockers or beta blockers. Quit smoking, of course, that's always a helpful thing. So with acute glomerulonephritis, as I said, it's going to be abrupt with the facial swelling. It's going to represent that they've been diagnosed with strep throat in the past 14 days. You're going to have the edema, specifically in the face as well. You can, as I talked about, hematuria would be noted in the urinalysis. They could have protein in the urine as well. It could be mild, or it can be a lot of protein, moderate to severe. It depends on how the patient's presentation, but typically when they come in with a swollen face, the first thing we'll do is work them up for, did you have strep throat in the last 14 days, or do you have lupus, are you diabetic, or are you hypertension? So again, looking at the etiologies, because these folks present themselves and the same signs and symptoms and the same interventions for both. But remember, with acute, I can treat it and be done with it, right? And here's your edema of the face, around the eyes, dependent edema of the hands, upper extremities, headache, nausea, vomiting, fatigue with the malaise, anorexia, not hungry, don't want to eat. Collaboration of care. For the chronic glomerulonephritis, these folks need to have neurology involved. The dietitians are very important in the acute exacerbation for whether it's chronic glomerular-driven lupus or if it's strep throat, because you want to put high carbohydrates in their diet, again, to hold on to protein to keep the kidneys from breaking it down because they're in stress. Again, with your strep throat folks, remember your teenagers, pediatric population, so that's where your teachers come involved, teaching parents to recognize what has happened and how to prevent it from happening again if the child has another recurrent issue with strep throat. Diagnostics I've gone over. I think there's one in here I wanted to. We can do a 24-hour urine, which means we give the folks a big red jug, and they go home and they collect their urine, whether we give them a hat or we give them a hat, let's put it that way. And they pee in the hat and they pour the hat into the red jug for 24 hours, and then they take it to a lab. And it's assessed over 24 hours what kind of What does the creatinine clearance look like? What does the BUN levels look like? What is the pH level? So urinalysis is a sample of urine. This is a 24-hour sample of urine. So the only analogy I can give you is when you talk diabetes with Miss Perrone last Friday, an A1C is a blood test that we can look at how severe someone's type 2 diabetes may be in sense of sugar in the bloodstream over 3 months. Okay, so that's an analogy of a 24-hour urine in comparison to an A1C level. Diagnostic tests, obviously we can do a throat culture to reconfirm strep throat. We've talked about our ESRs and our CRPs for inflammatory markers. They're generic. They're not going to tell me where the infection is. It just tells me where I have. We can do the CUB, kidney urine bladders, kidney scans, biopsies, just, the whole, if we're concerned about some form of kidney cancer. Your goal, I've talked about the goal, decrease the inflammation, stop the destruction of the glomerulus, because if not, especially with chronic, these folks will end up on dialysis. Corticosteroids can help, short-term prednisone can help for the inflammatory process. Immunosuppressive drugs, people with lupus will be on immunosuppressive drugs. So the same thing when I talked about ulcerative colitis, immunosuppression drugs. Rheumatoid arthritis, these are chronic inflammatory disorders that we need medications to reduce the immune suppression of the body. So that puts them at higher risk for infections. I talked about ACE inhibitors are on here. I would suggest that if someone had high blood pressure from an acute attack from strep throat, that we could do a short-term lisinopril. Remember your Pril sisters for ACEs, but for chronic lupus, for example, they're going to be on beta blockers or calcium channel blockers. Not only with the sodium restriction and the fluid restriction for both acute and chronic exacerbation, diuretics will, believe it or not, jumpstart the kidneys because one of the signs and symptoms is oliguria, which is no urinary output. So be mindful when we talked back in the day, module 1, your minimum output of urine per hour is 30 mLs. That tells you have adequate kidney function. Oliguria, obviously, we don't have adequate kidney function. So diuretics, your high ceiling loop diuretics, such as furosemide, which is Lasix, will jumpstart your kidneys to make urine. And then obviously we're avoiding foods that are high in sodium and potassium. I mentioned strict INOs. I mentioned we may restrict protein, but we're going to increase our carbohydrates so that we can get the kidneys to stop breaking down protein. You need protein to heal. Amino acids in your body is protein molecules. Bed rest for acute phase because of the malaise laboratory tests I talked about. The immunosuppressive therapy is going to be used for your chronic care patients with lupus. This is your assessment, so I'm repeating myself. I don't think there's necessarily. I could elaborate on the abdominal flank pain, of course, because of the left and right kidney involvement, whether it's acute or chronic. Shortness of breath. If there is pulmonary edema, you would hear rales and crackles, especially in the bases. The change in urine is going to be the hematuria and the azotemia, which is that tea-colored look. Kidney disease, of course, can always cause glomerulonephritis. So those are some of another chronic disease process. I think that's kind of covering the most of it. The goal, of course, especially for chronic, is maintain your urinary output, 30 mLs or greater per hour. I talked about the dietary intake, demonstrating no signs and symptoms of infection, so no fever, white blood cell counts come back to normal baseline. No alterations in skin integrity. Remember, if you have a lot of if you have any kind of edema and it's pitting edema, which it would be because you're holding on to fluid, the skin integrity is at risk for opening up so that the fluid has someplace to go. So be mindful of that in sense of making sure we reposition our patients accordingly in bed and get them off of those prominent areas like the lower back for sacral wounds, elbows if they're on oxygen behind the ears. I think we've talked about those pieces. Definitely limiting visitors. because your chronic patients who are in exacerbation, because you definitely make sure they're not bringing anything that somebody in the bed who's already immunocompromised can catch. Don't want to do invasive procedures when they're in an exacerbation. Monitoring for infection we talked about. Just some other pieces here that I think are fairly self-explanatory. Kind of goes along a lot of what I talked about in sense of implementation. I love the fact of keeping bed free of crumbs. Believe it or not, that can cause pressure ulcers. Always a team approach. Never work at the bedside by yourself. And anorexia is common with acute and chronic exacerbations. Not hungry, too much fluid on board where it's not supposed to be. So you're sick. I think we're self-explanatory. Evaluation: are you having a reduce in weight? The swelling is going down. Your urinalysis is coming back clean. The tea-colored urine is clearing, etc. So take your clinical manifestations, throw in your interventions, and then tell me what you expect outcomes are going to be like in a perfect world. All right. So the older adult piece and how it fits back. Sometimes it's called intestinal nephritis. So I'm not testing on this, but I always find it kind of fascinating that sometimes folks that are on long-term omeprazole for the PPI inhibitors for peptic ulcer disease, and we're treating recurrent H. pylori, for example, with antibiotics, can set up the predisposition for that poor flora bacteria. And that can also, because your kidneys eliminate and excrete, can also set up some nephronitis from peptic ulcer disease. It's not testable, but everything you put in your mouth comes out, obviously urinating out wastes and then making stool. So it all has itself to think about. Pregnancy, women who are pregnant with lupus, again, you're going to go back to the conversation where we have to make sure that the flare-ups are not a risk factor for mom or fetus. Watching the use of corticosteroids, immunosuppressors during pregnancy. So you might have an increase in flare-ups because of that. But these women are high risk to begin with, and they should have specialists on board. No offense to just straight up L&D or OBs, GYN docs. These folks should have high-risk providers that are specialists in this area to manage the care of the mom and the care of the fetus. I know this was long and extensive. Make sure you have taken plenty of break periods. Do the activity lesson I posted and the case study I posted, and hopefully we can meet face to face. If not, we're going to hold collaborate online for class. Thanks for your patience. Take good care and be safe this weekend.